Hello, everybody, and welcome to the Hughes Clues Renal Dysfunctions. This is part one. We're going to begin with what does the kidney do? Well, the kidney filters blood, and that filtration results in the removal of water and waste. And when we think about waste in this course, we really think about major waste, and that's potassium, phosphorus, blood urea, nitrogen, and creatinine. Now, the kidney has other jobs, such as metabolic functions, and what I mean by this is that the kidney secretes a substance known as erythropoietin that stimulates RBC production. The kidney makes and can either excrete bicarbonate or it can excrete hydrogen if the patient is overly acidotic. The kidney can also regulate calcium absorption by activating vitamin D. So vitamin D comes from the sun and from the diet, but we need activated vitamin D to help with the absorption of calcium, and the kidney makes the substance that activates vitamin D. And then the kidney also ensures that proteins and red blood cells are not lost in the urine because we need those things and we don't want stuff that we need dumped out into the urine. So the kidney is also like a gatekeeper to ensure that things stay in the body and don't go out of the body. Now, what about renal dysfunctions? So there's two types of renal dysfunctions. One is acute and one is chronic. So we're going to talk first about acute kidney injury and what defines that. Who's at risk? So acute kidney injury means, just like what always acute means, something that happens suddenly. So a kidney dysfunction or injury that happens suddenly and the kidney's not able to do its job, which is to filter the blood, remove the waste and water. So who's at risk? Well, essentially those individuals who are hospitalized, and those individuals who also have comorbidities. In other words, individuals who have pre-existing cardiac disease, diabetes, and hypertension. And it's no wonder that individuals who are in the ICU, those are the patients who are truly very, very sick, those are at the highest risk from not only getting acute injury, but to not become well from it and therefore die. Compare the causes of prerenal AKI, intrarenal AKI, and postrenal AKI. So from these three terms, prerenal, intra, and post, you can identify that the acute kidney injury is classified. So why is it classified? Well, it has to do with treatment. Physicians will determine where the injury has occurred, and then that way it can help identify a specific treatment for that injury. And when we talk about prerenal AKI or acute kidney injury, we're talking about, fancy way of saying it, factors external to the kidney that decrease renal blood flow and lead to decreased glomerular perfusion. So probably the most common cause of decreased renal blood flow is cardiac output. So if the cardiac output goes down, then that means the kidney doesn't receive an adequate amount of blood volume. The kidney cannot do its job whenever there is an inadequate amount of blood volume, and that causes the kidney to decline or not work as well. And I've kind of listed several causes of a decreased cardiac output. I know I've got hypovolemia listed there, and that is true. That is one cause of decreased cardiac output, but you have to notice that even in heart failure where there's plenty of volume, and in fact there's too much volume, the heart is still not pumping well, and so the cardiac output still goes down. And then you have some other things that occur because of septic shock or neurogenic shock. The cardiac output goes down because of peripheral vascular vasodilation, and then there's some things that occur with the renal artery itself. If there's problems with either the renal artery is occluded or there's some kind of blockage, then that ultimately leads to the same thing of the kidney not getting the blood flow that it needs. When we talk about intrarenal conditions, these are things that actually physically either damage the kidney tubule, that's part of the nephron, or the glomerulus, that's the front part of the nephron. And if any of the kidney nephron is damaged, then the kidney nephron can't do its job, which is to filter water and waste. What would cause kidney nephron damage? Well, if you have an individual who has a decreased cardiac output, say from heart failure and they're not able to treat it very well, then as the cardiac output stays down for prolonged periods of times, then that will ultimately cause renal ischemia. And if it's not fixed quickly, then the kidney can then move into intrarenal failure. So essentially, pre-renal failure that's not fixed in a timely manner will result in intrarenal failure. Nephrotoxic injury, this is kidney failure that occurs because of drugs such as the NSAIDs or penicillins, gentamicin, just about many drugs do cause or can cause kidney injury. And then contrast dye is another drug that can cause nephrotoxic injury. Myoglobin release, when you do your burns and you've already done the trauma perhaps, then you'll know that any kind of imaged injury to the muscles can cause myoglobin to be released. This will cause kidney injury, and then a whole host of other problems which you can read at your leisure. Postrenal failure, not a very common cause of acute kidney injury, though it can occur, and this is our conditions that cause mechanical obstruction of urinary flow. So let's say an individual has some kind of a male has some kind of prostate injury, then urine becomes retained because they are not able to get rid of their urine, or the urine flow is bad. And then this can cause a backup, which will ultimately lead to hydronephrosis. Kidney stones can also cause hydronephrosis, and then this can lead to intrarenal failure. So not very often do you see postrenal. You're usually not quizzed about it, but it can occur. So let's use all of this information that I just addressed and do a scenario. And we've got a nurse who's caring for a 78-year-old male. Their second day post-operative following a colon resection for a ruptured diverticulum. Their only medical history is diverticulosis. The surgery was uneventful and the patient's NPO. And then when you look at the assessment characteristic, the nurse notes that there's 30 cc's of urine for the last hour, 25 cc's of urine in the previous hour. And then there's your vital signs that are listed. Note that the patient's weight is 80 kilograms, and the current medications the patient is receiving is gentamicin. And then they're also, because they're NPO, they're receiving Ringer's lactate 150 cc's per hour. So let's look at the assessment features and determine if acute kidney injury is present or there's a risk for acute kidney injury, and then how much urine should he produce. So the reason why we start with that is because the kidney is responsible for removing waste and water. And so the only way, or the easiest way, that the nurse can determine whether the kidney is working, well, how much urine is there? And there is a specific amount of urine that should be produced, and it is weight-based. So if this patient's 80 kilograms, the minimum amount of urine that an individual should do is 0.5 mils per kilogram per hour. So this patient should be producing 40 mils of urine per hour. And if you look again at the assessment characteristics, the previous hour they were producing anywhere from 30 to 25. So that is far less than the minimum. Now, I know that even now in intensive care units, nurses will say, well, they need to produce 30 mil, and that really is old school. If you're a renal specialist, a nephrologist, they will tell you that the patient should be producing 5 mils per kilogram per hour at minimum. Now, the other defining marker is, even though there is a mil per hour, and let's say a patient produced 30 mils in 1 hour, if the overall day of urine production is 500, then it's considered that the patient's doing okay. However, if the urine output is less than 400 mils per day, then that also should be a marker of concern for the nurse. When we talk about kidney dysfunction, we do talk about specific phases. You can see it's listed that in the oliguric phase, we know what oliguria is, less urine than normal, that patients will produce less urine. More on that later. So which classification of the acute kidney injury could this patient be developing, and why would we think that? So let's look we've already identified really the causes of prerenal, intrarenal, and post. So which one does this patient have? And so we look at our patient and we see that they're probably at risk for prerenal or intrarenal acute kidney injury. There was nothing in the scenario that said that the patient has an obstructive disorder or not able to produce urine. We really think, and most patients in the ICU are at risk for either of these two, prerenal and intrarenal. So we know that the first criteria that determines in any kind of acute kidney injury, excuse me for my stuttering, any kind of acute kidney injury is a low urine output. So less than the criteria of 0.5 mils per kilogram per hour or less than 400 mils total in one 24-hour period. So we see that puts the patient at risk, and we know that it's either of these two because we've not heard anything in this scenario that indicates the patient has a problem with getting urine out of their body. So let's look. If the patient had prerenal failure, then this is going to be from hypoperfusion. That's the fancy way of saying a decreased cardiac output. And when we look at the blood pressure is a little on the low side, but the heart rate's normal. So in normal individuals, if the cardiac output went down, then the heart rate would go up. That's compensation. And so we don't see that. So we have to think, maybe that's not the issue. Also, if the patient was to be hypovolemic, he would have to be somewhat dry, and his fluids are running at 150 mils per hour, and that's a pretty decent amount of volume that's going in. So it really doesn't appear that dehydration or a decreased cardiac output is the case. So let's move on to another possibility, and that's intrarenal AKI. So that's damage to the kidney nephron. He is receiving gentamicin, and that is a potentially nephrotoxic drug. Now, you could also say, how do you know? Well, really, the initial thought on which AKI it is simply from the history. And we don't have anything in the history that says this patient has heart issue. And we do see in the history that there's gentamicin. And that's another reason how I came to the conclusion that, maybe intrarenal is the problem. But that's not really going to be the key identifier. That's just kind of a clue in our map to get to the problem. So we have to look at other things, and what we look at are the lab values. So let's look at his lab values. We see the serum sodium is a little on the low side. The potassium is 4.8. And then we identified earlier that potassium is a waste. So if the kidney's working well, potassium should be removed. And we also see the BUN is slightly elevated as well as the creatinine. So we have a big clue here that there's definitely something going on with the kidney from the fact that the BUN and creatinine is up. No matter what problem it is with kidney, BUN and creatinine is a big, big clue to all things kidney because those are wastes, and those are wastes that are removed by the kidney. We're also going to look at the urine analysis because this gives us additional tips to figuring out what's going on. So what clues do these labs provide? So we see that the BUN and creatinine are elevated. So we know the kidney's not removing these wastes. So we know that there is an issue with the kidney. Now we know that there is a low urine output, so the kidney's not getting rid of water, and then there is an elevated serum creatinine. So those are two key characteristics of all things kidney dysfunction. Low urine output, because that's the water part, and poor waste removal, there's the waste. So really, water waste, it's always in our thought process with all things kidney. Then, as I said, the serum sodium level is slightly decreased, but if you look back at the urine output, we also see that there is sodium in the urine, and that is a key clue that this is an intrarenal acute kidney injury, because when there's more sodium in the urine than normal, that is an indicator that the kidney is just kind of dumping sodium, and usually the kidney doesn't. The kidney holds on to most of the sodium because the body needs it for a lot of functioning. So the kidney is not concentrating urine. How do I know whether the kidney's concentrating urine? I look at the specific gravity, and it's low. So let's take a side trip about specific gravity. Now, most students will tell me that this is confusing, so I want to stress that there's usually only one question about specific gravity, if at all. So stress not, but you're also going to be taking care of patients, so I do want you to understand. So let's look again when we define what's the kidney's jobs: waste and water. And therefore, the specific gravity, when we look at the urine, the specific gravity is the ratio of how much water to how much waste is in the urine. So what I've got here in this rectangle, this is a container, and it's filled with urine. So when you think of specific gravity, that sounds like a really fancy term. Just think of urine concentration, urine osmolality. Those are really, for our purposes, for nursing purposes, pretty much the same thing. Now let's think about your urine in a normal situation. Because when kidneys are working well, and if you were to drink 2 liters of water, so what would your urine look like? You would have what is meant to be represented in this rectangle. You would have a container filled with urine. So lots of urine, and then the urine would be very pale yellow. So the pale yellow is meant to represent that, yes, water will be removed, and lots of it, but also at the same time the kidney's going to remove some waste, the normal amount of waste. There's just a lot of urine because you are getting rid of, or your kidneys are getting rid of, more water than normal, but it is still a yellow color because you are still getting rid of some waste. So you would see that the normal urine specific gravity, and there's ranges, I like the 1.002 to 1.28, and you see that in this particular scenario, I've just made it up, and I've said that the urine, even though there's a lot of urine and it's pale yellow, meaning there's a little bit of waste removed, it's still in the normal range. So if the kidney is doing its jobs, which is to get rid of water and waste in the appropriate ratio, this value, 1.002 to 1.028, will always be present because that's the way the kidney works. The kidney gets rid of water and waste, and it gets rid of water and waste in the appropriate concentration. In the appropriate concentration. So that's normal. Now let's continue with normal. Let's say, for instance, that you are exercising. You're going to run 3 miles in July at 3 o'clock in the afternoon when it's about 100 degrees outside, and you forget to bring your water bottle. So after you finish your run and you decide that, or you need to urinate, what would your urine look like? And this rectangle again represents, if you collected it in a container, what would the urine look like if you were somewhat volume depleted. And you know that there would be very little urine, and the urine would be fairly dark. So why is that? Well, because if you are somewhat volume depleted, then the body, the kidneys specifically, will hold on to water. And that's why there's very little water. And then the kidney is still doing its other job, which is to get rid of waste. And so the urine would be dark because in ratio proportion, there is very little water to the normal amount of waste. Again, you would still see the specific gravity in the normalish range, and that says to you, my kidneys are doing the job they're supposed to. They're supposed to hold on to water when the body doesn't have a lot of water in it, but they're still supposed to always get rid of waste whenever I urinate. So that's what this dark and less-ish urine represents, that the kidney is still getting rid of some water, but it's definitely still getting rid of the normal amount of waste, and that's why the urine is much darker than normal. So let's go back to our scenario. When we look at our patient scenario, we see that the patient's making very little urine, 25 mils per hour. And even though he's receiving a lot of fluids per hour, 150 mils per hour, the kidney is not removing water. Now let's look at the other portion of the urinalysis, and that's this patient's specific gravity. The specific gravity is low. It's 1.008. So the kidney is therefore also not doing its other job, which is to get rid of waste. So if you go back to the previous slide when I said to you, whenever your kidneys are making very little water, it means that your volume depleted and therefore you're still getting rid of the normal amount of waste. So in this scenario, two things that the kidney is supposed to do, which is get rid of water and get rid of waste, is not occurring. And that's the definition of kidney dysfunction. The kidney is not doing either of its job. It is not getting rid of enough water, and because this urine is still very pale and the specific gravity is low, then we know that it's not getting rid of enough wastes either. So both factors are not present. The wastes are not being removed, the water is not being removed, and that is the definition of kidney dysfunction. Now let's look at another clue that was present in the urine. The urine is positive for casts. Well, what are casts? And what I've shown you here is what it would look like on a slide, which you'll never have to identify, but this is what the laboratory personnel see. They see this little stuff in the urine. And what are casts? Well, casts are dead tubular cells. So remember that the nephron is made up of a glomerulus and a tubule. Proximal convoluting tubule, the loop of Henle, and the distal convoluted tubule. Those are the nephron tubules. And all along the nephron tubules, all these is several layers, actually a couple of layers of cells. And it's those cells that are the ones that decide what needs to go in the urine and what needs to come back into the blood. And those tubule cells, when they become damaged, then they slough off, just like if you have a sunburn and the skin on your nose gets burnt, and a few days later your skin will slough off when it's dead. And that's the same thing in the kidney nephron. Whenever these kidney nephron cells die, they'll slough off, and that's what casts are. They are dead nephron cells, and they can be identified or seen in the urine. So what does this mean? Well, whenever these cells slough off, it means that the cells have died, and there's an actual term for it, acute tubular necrosis. So the bottom line for you is that whenever casts are present, then you know that a tubular cell has undergone necrosis, acute tubular necrosis, and that means your patient has intrarenal acute kidney injury. Now, I do note that the potassium is slightly elevated, so it's going up, and so you do have to watch the potassium level also for many obvious reasons. So notice that these cells kind of clump together, and that can also cause an obstruction too. So that will also damage the kidney nephron. So these casts are bad for the kidney nephron for many different reasons. Let's return to our scenario. We've already identified that this patient has intrarenal AKI. Kidneys are not removing waste and water as they should, and there is intrarenal damage. So on post-op day 3, his weight is measured at 82 kilograms. So he was at 80 kilograms, and in a day he has now increased his weight to 82 kilograms. So what does this indicate? Well, it doesn't mean he's been eating delicious hospital food. He has been NPO. So what does a weight gain mean? Well, it means that the kidney is holding, or the body has an increased volume. The kidney's holding onto water. It's not getting rid of water. And 2 liters of fluid means that he has gained 2 kilograms of weight means he has gained 2 liters of fluid. That's what's great about the metric system. 1 liter, 1 kilogram. So again, we've just confirmed that his kidney's not doing what it's supposed to do. It's not getting rid of water and waste. Now, I've given you this tip that 1 liter equal 1 kilogram of weight, and this is an important tip for many things, because let's talk about our heart failure patient that we've talked about in detail before. And we know that heart failure patients hold on to water, and that's why your nephrologist or your cardiologist will absolutely throw a hissy fit if you don't weigh their patient, and if you don't weigh their patient first thing in the morning, because weight gain is an indicator of holding on to fluid, and so that's how it's used, and it's an indicator of worsening heart failure or worsening kidney disease. In addition to the weight gain, our patient appears to be confused. He doesn't know the date or the place, and he did earlier. He's complaining of nausea. He's not interested in eating. So what could be the cause of these signs and symptoms? Well, the cause of his confusion could be uremia, another fancy term. So let's define them because they're used quite often on exams, whether it's critical care, ATI, or NCLEX. So what does it mean to have a patient who has azotemia? Well, azotemia very simply means that they have elevated wastes in the body, either elevated BUN and or creatinine. And then a lot of times you'll hear physicians say, well, the patient's uremic. And what that means is that the patient has elevated wastes, BUN and creatinine, and they have signs and symptoms. In other words, people can have elevated BUN and creatinine and it doesn't adversely affect them. But the reason why I say waste, that BUN and creatinine are waste, is because they're harmful to the body. And they can cause several different problems in the heart. They can cause pericardial effusions. So they can cause, or BUN and creatinine can cause problems. And so when an individual not only has a BUN and creatinine that's elevated, but if they're showing signs and symptoms, then it's really known that these wastes are adversely affecting the patient. So signs and symptoms that can occur with an elevated waste or BUN and creatinine level are confusion, nausea, vomiting, and diarrhea, and itching. So this patient is showing that not only does he have elevated waste as evidenced by the lab values, but that these elevated waste levels are adversely affecting him. So we've identified previously that the patient is in the oliguric phase. Well, what does that mean, and what are the 4 phases of acute kidney injury? So these 4 phases are the initiating phase, so that would be the time at the insults, whether it's giving gentamicin or receiving gentamicin, or whether it's a decrease in cardiac output. And then the oliguric phase is within 1 to 7 days from the insult, and it's defined as urine output less than 5 mils per kilogram per hour, or a total of less than 400 mils per day. Now, what's the care priority for an individual in the oliguric phase of acute kidney injury? Well, the care priority is watch those wastes that are going up. In other words, the potassium can be going up because it's not being removed by the kidney, and so therefore, and other side effects such as I mentioned, problems with pericardial effusions or some other complications that are occurring because of the elevated wastes. Now, this is a fairly extensive list or detailed list, and I know that there's a lot of information on every exam. So if you feel like this is an overwhelming amount of information, then just write it on your exam sheet. The diuretic phase is a gradual increase. In other words, the kidney function or the kidney itself is trying to recover. So this is kind of a beginning recovery phase. The kidney function is still poor. So there is usually an elevated BUN and creatinine level, but because the kidney is recovering slightly, there's a lot of urine output, and that's how you know that the patient is in the diuretic phase, just like it sounds. They're putting out 1 to 3 liters, but it's quantity and not quality. In other words, the kidney's still not getting rid of wastes. It's dumping willy-nilly substances in the urine instead of thinking about what it should keep and what it should dump. And so this is actually a fairly dangerous time for the patient because the kidney is just dumping water, dumping certain electrolytes, and so therefore they can have electrolyte imbalances and volume depletion. Then in the recovery phase, note that it can take 12 months for the kidney to recover from the initial insult that occurred up here. And then the outcome is influenced by, again, the overall health and or age of the patient. Because if the patient has a lot of comorbidities and they're 90 years old, well, then you could understand that likely they're not going to recover very quickly, if at all. So we've talked a lot about what has happened in our patient scenario because we identified that he had intrarenal acute kidney injury. Well, what if I had made up the scenario that it was a pre-renal situation? So what would the scenario look like and how would you, the nurse, identify it? So again, if you go back to the causes of pre-renal, it would probably be something like this patient had gone to surgery and perhaps they had a history of heart failure, or perhaps they became septic after the surgery. So those would be the scenarios that would kind of lead you to suspect that this is a pre-renal problem. Heart rate went way up, the blood pressure went way down. And what would the laboratory value look like? Well, you can see in any time there is any kind of acute kidney injury, the urine output's going to be less than zero point 0.5 mils per kilogram per day or less than 400 total per day. Now let's look at these serum analyses. So again, we go to the healthcare team will identify acute kidney injury when there's an elevated serum and or BUN level, serum creatinine and BUN level, and then I've identified the urine amount. Pre-renal is going to have the causes, and then tell me something or think about how does the kidneys respond whenever the cardiac output goes down. And so if you immediately thought of RAS, because we've kind of drilled that into your head just about in every single scenario, that as soon as the cardiac output goes down, which is a key indicator of or key cause of pre-renal acute kidney injury, the kidneys go, yo, where's my blood? And then they initiate the RAS, the renin-angiotensin aldosterone system. And so we know that angiotensin is going to ultimately form to angiotensin 2, and that's going to cause vasoconstriction. That will cause the release, and angiotensin 2 also causes the release of aldosterone. When aldosterone is released, the kidneys hold on. I put hold on to water. I should have put, I've got it there. I'm sorry. The kidneys hold on to sodium, which ultimately causes the retention of water. So let me rephrase that so that I don't mess this up. So we've got cardiac output goes down, kidneys initiate RAS. The last A in RAS is aldosterone. The kidneys then hold on to sodium, which then holds on to water. When the kidney holds on to water, the urine output goes down. So it's always the opposite. If the kidneys are holding on to something and it stays in the blood, it's not being put or dumped into the urine. So when the kidneys hold on to sodium, the amount of sodium that should be in the urine goes down. So we see here on our lab values that there is a decreased level of sodium in the urine. That's the reason why. The increased level of sodium in the blood, decreased levels of sodium in the urine goes down. Now the specific gravity or the concentration of the urine is okay. We see that it's on the high side, 1.022. So what's the story with this? Why? Because what I want you to think of is that pre-renal failure is basically a stressor. The cardiac output has gone down, but the kidney nephrons are still working. The kidneys have an amazing capacity to tolerate a decreased cardiac output far better than, say, the brain, because you already know that as soon as the cardiac output goes down, well, the brain kind of gets a little fuzzy, the patient gets a little confused. The kidney nephrons don't like it when the cardiac output goes down, but they still start or try to do their job. And the kidney nephrons, whenever they're trying to do their job, that is getting rid of water and waste, they really only have one option available whenever the cardiac output goes down. They can't cause the heart to pump faster by squeezing the heart. The only thing the kidneys can do is RAS. So whenever there is signs and symptoms of RAS, such as low sodium in the urine and higher sodium in the blood, then we know that the kidneys are still working. And what do the kidneys do with RAS? Well, they hold on to water. And even though it's likely inappropriate, It's all they can do. It's all the kidneys know to do. So the kidney nephron is still alive. It's still working. It's still able to compensate in the only manner it knows how, and that's to do RAS. So the kidneys are sick. They're struggling, but they're still doing RAS. They're still doing a lot of RAS. A lot of the nephrons are just cranking out that aldosterone. Now, I said that the kidneys have an amazing tolerance for low cardiac output, and that is true. However, there is at some point when a continued diminished cardiac output is present, then the kidneys will start to decline. So in other words, if the problem's not fixed, the cardiac output does not go up, then the nephrons will die. They will move then into intrarenal failure as the nephron dies. So probably what I have in blue is really the key information. That pre-renal failure, the kidney nephron is sick, it's struggling, but it's alive and it's still working and it's doing RAS. And that's why you see the different urine products and different blood analysis than what you see in an intrarenal. I hope this has been helpful. If you have any questions, email me.